Hello guys, welcome to ACE Anesthesia. Today we'll be discussing on the topic pulmonary function test. In this video we'll be seeing what are the uses of the pulmonary function test, what are its indications, contraindications, and coming to the pulmonary function test as a whole, where I have classified into test for mechanical ventilatory function, test for gas exchange, and test for testing out the cardiopulmonary reserve. So coming to what are the uses of the pulmonary function test. So uses of this pulmonary function test, basically we can divide into number one is to identify the type of the lung disease. Okay. Second is to identify the severity of the lung disease. Third is to identify the progression of the disease, that is over the time any effect to the treatment or response to the treatment that can be identified by the PFTs, or also any adverse effect of certain drugs like bleomycin. All this can be identified by the pulmonary function test. Another use of it, that it is used or done before surgery to predict the post-operative pulmonary complications, right? So these are the uses of the pulmonary function test. Now what are the indications of the pulmonary function test? Indications, it is done in patients like COPD, asthma, patients who are on bleomycin treatment, patients who are posted for major abdominal surgeries or pulmonary surgeries, that is thoracotomies or any video assisted thoracoscopic surgeries or lobectomies, etc. It is also done in the patients who are undergoing lung transplant also. We have to do the pulmonary function test, right? So we have finished the indications and uses of the pulmonary function test, right? Next, coming to contraindications of the pulmonary function test. So pulmonary function test is basically contraindicated in patients who have had a recent history of myocardial infarction or angina, right? One of the contraindications. Second is patients who have had recent thoraco-abdominal surgeries within 2 months, right? Third is the patients who are having thoracic or abdominal vessel aneurysm, okay, or cerebral aneurysm, right? Another patient where we have to avoid is any recent eye surgeries, okay, within 2 weeks. We have to avoid the pulmonary function test, right? Because it basically involves blowing against a closed maneuver. It requires some amount of straining. So these are the contraindications of the pulmonary function test, right? So coming to first portion of the pulmonary function test is to test the mechanical ventilatory function, right? For test for the mechanical ventilatory function, we can have the bedside pulmonary function test, or we can have the spirometer or the spirometry that is done, right? So following are the bedside pulmonary function test, we will discuss one by one, right? First is the Sabre's breath holding test. In Sabre's breath holding test, we ask the patient to take a deep breath and hold it for as long as possible, right? And once they are leaving the breath, we count the number of seconds they have held the breath. In Sabre's breath holding test, normal will be more than 25 seconds, which indicates that they have a good vital capacity of more than 3500 ml. If the breath holding test is 15 to 25 seconds, the vital capacity is around 2500 to 3000 ml. Less than 15 seconds of breath holding, that is vital capacity is less than 2500 ml, right? So this is the Sabre's breath holding test. Second is the watch and stethoscope test. So in watch and stethoscope test, you ask the patient to take a deep breath and exhale it as fast as possible. So we have to count the number of the seconds within which the air is exhaled. So we keep the stethoscope over the trachea and count the number of seconds within which it is exhaled, right? In a watch and stethoscope test, normal duration will be 3 to 5 seconds, right? If it takes more than 6 seconds, it indicates that there is an obstructive pathology. Okay. If it is less than 3 seconds, it indicates that it is a restrictive pathology. Right. So we finished the watch and stethoscope test. Next, coming to the Schneider's match blowing test. So in Schneider's match blowing test, actually the patient sits with chin rested and matchstick at the same level. Okay, the patient is asked to blow the matchstick with open mouth without any pursing. The distance between the patient and the matchstick is about 6 inches, right? So patient should be able to blow with open mouth, right? Like this, without pursing the lips. So this we will be calculating if the patient is able to blow it or not. So through this, we will be determining the FEV1 and the maximum breathing capacity. So in Schneider's match blowing test, okay, if at this patient is able to blow the matchstick, then his FEV1 will be more than 20 ml. Sorry, it will be more than 1.6 liters, or the maximum breathing capacity, it will be more than 60 liters per minute. Okay. So this is the Schneider's match blowing test. So we have what is also called as the modified Schneider's match blowing test. So in modified Schneider's match blowing test, we will see the various distances, that is at 9 inches if patient is able to blow, then his maximum breathing capacity will be more than 150 liters per minute. Okay, if at 6 inches means it will be more than 60 liters per minute. If it is at 3 inches means his maximum breathing capacity is 40 liters per minute. Okay, so this is the modified Schneider's match blowing test, where at various distances also we can calculate the maximum breathing capacity, right? So next we come to Green's cuff test. So we finished Schneider's and modified Schneider's. Next we have the Green cuff test. So Green cuff test will basically help us to determine the effectiveness of the cuff and patient is whether he is able to expectorate the secretions. So it helps us also to tell about the patient's post-operative pulmonary complications. So if the patient is able to cough out effectively, that indicates that his FEV1 is more than 15 ml per kilo, FVC is more than 20 ml per kg, and his maximum breathing capacity is more than 200 liters per minute. So this is the Green cuff test. Next we have the two devices. One is the Wright's peak flow meter and DeBondo's whistle, which will tell us about the peak expiratory flow rate. So normally in case of males, the peak expiratory flow rate will be 450 to 600 liters per minute, and in females it will be 350 to 500 liters per minute. These are the normal values. Anything less than 300 means there is a decrease in the peak expiratory flow rate. So apart from all this mechanical ventilator functions, we should also check clinically for the respiratory rate, saturation of the patient, and ABG of the patient at room air. So these are the bedside pulmonary function tests, which will help us getting a quick update about the patient's pulmonary status, especially the mechanical function, ventilator function status. Okay, next we will move on to spirometry. So spirometry, it is basically used to measure various airflow volumes and capacities. Some of the prerequisites which are required for the spirometry is that patient should have stopped any kind of bronchodilators at least 4 hours to 6 hours prior to the procedure, right? And also in spirometry they should be wearing a loose fitted clothes, nothing that could restrict their breathing efforts. And also in case of any dentures, it can be left in place if it causes a good seal. Also in spirometry, the patient is avoided from taking any large meals, okay, about 2 hours prior to the procedures. And also whenever during the spirometry is performed, the nose is clipped and patient is just blowing through the mouth. So in case of bronchodilators, like in case of salmeterol, right, these have to be stopped like about 24 hours prior to the surgery, because these are very long acting bronchodilators. Whereas like in ipratropium, they have to be stopped like 12 hours prior. But our usual salbutamol suffices. Usually we can stop up to 4 to 6 hours prior to the spirometric procedure. So in spirometry, we will be basically seeing we'll be seeing the static lung function test and the dynamic lung function test. So in static function test, we have 4 volumes and 4 capacities, whereas in dynamic lung function, we will be seeing FEV1, FVC, peak expiratory flow rate, maximum breathing capacity. So in the static lung function test, it will basically tell us about the capacity of the lung and the chest wall, whereas dynamic lung function test will tell us about the elasticity of the airways that is present. So this is the typical spirometry graph which we will see. So the typical spirometer is when the patient is sitting with all the prerequisites. He is told to take a deep breath and then have a normal tidal respiration, that is breathing in and breathing out. Once that is done, he is told to take a deep breath followed with an expiration, followed maximum as much as possible. So such a graph will appear during the time. This is called as the spirometric graph. So in the spirometry graph, so the amount of the gas that the patient breathes in and out, this is in a normal respiration, this is called as the tidal volume. The tidal volume value is usually about 6 to 8 ml per kg, usually approximately is 500 ml for a 70 kg adult, right? So this is the volumes. So first we will start with the static lung function. We will see about the 4 volumes and the 4 capacities. So first volume is the tidal volume. Next we will come to inspiratory reserve volume. So inspiratory reserve volume is the volume of the air which can be inspired in excess of the normal tidal inspiration. So patient breathes in normal tidal volume and then breathes in excess of the normal tidal volume is the inspiratory reserve volume, right? So inspiratory reserve volume, the value will be approximately about 3.5 liters. Next we will come to expiratory reserve volume. So in expiratory reserve volume is the amount of air which can be expired in excess of a normal tidal expiration. So in excess of this normal tidal, whatever extra amount of gas that can be expired, that is called as expiratory reserve volume, which is usually about 1.5 liters. Then we come to some amount of gas which stays in the lungs irrespective of the maximal forceful expiration, that is called as the residual volume, right? So this is called as the residual volume. The normal value of this residual volume will be approximately 1.5 liters. So we have discussed the 4 basic volumes that comes in the static lung volumes. So next we will come to capacities. That is the 4 capacities. First capacity is the vital capacity. Vital capacity is the amount of air which can be maximally inhaled after a maximal exhalation. So vital capacity basically includes inspiratory reserve volume with expiratory reserve volume with the tidal volume. That will be the vital capacity. So whenever we are doing pre-oxygenation, we have to ensure that they take about at least 2 to 3 vital capacity breaths. Right. Another kind of capacity is the inspiratory capacity. Inspiratory capacity is nothing but inspiratory reserve volume along with the tidal volume will be the inspiratory capacity of the patient. Next comes the functional residual capacity. Functional residual capacity is the expiratory reserve volume with residual volume, that is the amount of air which is present in the lungs at the end of a tidal expiration, that is called as a functional residual capacity. So another capacity which is nothing but the total lung capacity. So the total lung capacity includes the inspiratory reserve volume, the tidal volume, expiratory reserve volume and the residual volume. Together normally it's about 6 liters, that will be the total lung capacity of the person of an average adult of about 70 kilos. So next we will be seeing about the dynamic lung volumes which I have told prior. So this is a graph which shows exhaled volume versus the time in seconds. So patient is asked to take a deep breath and exhale rapidly as possible within the first 6 seconds. We calculate the maximum volume that is exhaled during the particular time interval, that is called as the forced vital capacity, that is the FVC, right? So this FVC is the forced vital capacity which is decreased in case of an obstructive lung disease. So the amount of air that is exhaled during the first second, that is this amount of air that is exhaled during the first second of this FVC maneuver, this is called as FEV1. So FEV1 normally it is 75%, right? If it is 60 to 75%, it is mild obstruction. Okay, 55 to 60%, it is moderate obstruction. If it is less than 50%, it is severe obstruction. Okay, so this is the FEV1. So we find a ratio, that is FEV1 by FVC. This is FVC. This is also called as Tiffany's index. Okay, the ratio should be normally more than 70%, right? If it is less than 60%, it is mild obstruction, right? Okay, and if it is less than 70%, it is mild obstruction. If it is less than 60%, it is moderate obstruction, and less than 50%, it is severe obstruction. So this FEV1 by FVC ratio will also tell us about the obstructive lung disease and its severity. Okay, one more thing which we can determine by using this is the peak expiratory flow rate. Peak expiratory flow rate is the maximum flow rate which can be achieved after a maximum inhalation and exhalation rapidly during this FVC maneuver is called as the peak expiratory flow rate. Peak expiratory flow rate can be drawn by drawing a tangent to this FVC curve. The normal peak expiratory flow rate will be 600 liters per minute. Okay, this rate will be reduced in cases of obstructive lung diseases. So in this, this is drawn by drawing a tangent to this curve. Another thing which I had to tell, where what we determined by this FEC curve is FEF 25 to 75. That is the forced expiratory flow rate, that is during 25 to 75, that is the mid portion of the curve, is called as the FEF 25 to 75. This will tell us about the intermediate airways obstruction, right? So this is also another important thing which we have to remember, and the value normally will be about 300 liters per minute. Okay, so we discussed about FEV1, FVC, we have discussed about FEV1 by FVC, FEF 25 to 75, peak expiratory flow rate, and one more thing which we have to remember is that another important test which we perform during this pulmonary function test is the bronchodilator test. Okay, in this bronchodilator test, we give about 4 puffs of a meter dose inhaler, either salbutamol or it can be albuterol, and then after 10 to 15 minutes, we do a spirometry, that is we see for the improvement of the FEV1. Okay, if the FEV1 increases by more than 12% or increases by more than 200 ml, then it is a positive test, that is it can be because of conditions like asthma. If it is, that is due to asthma, right? If it is negative, then it may be because of COPD. So this will tell us about the effectiveness of a bronchodilator on the patient's airway post the spirometry. One more important test which we have to remember is the bronchoprovocation test, right? In bronchoprovocation test, this is done by the clinician if he suspects that the patient is having a hyperreactive airway. So in this, the spirometry will be normal, but if he is suspecting a hyperreactive airway, we do a bronchoprovocative test by using a non-specific muscarinic agonist like methacholine. Okay, after giving this, we check for the FEV1. If there is a decrease in FEV1 by more than 20%, then it is positive for the hyperreactive airway. So these are the important things which we derive from the FVC curve. One more important determinant which we can determine by this is the maximum breathing capacity. Okay, also called as the maximum voluntary breaths which can be taken. So in this, patient is asked to inhale and exhale maximally for a period of about 15 seconds, and this is extrapolated, okay, to about 1 minute. So normally the maximum breathing capacity of the patients will be about 150 liters per minute. Okay, this is reduced in patients with advanced stage or in case of obstructive lung diseases, right? The maximum breathing capacity will be reduced. So the next portion of the pulmonary function test is a test for seeing about the gas exchange. So this includes the 4 things, that is diffusion capacity of carbon monoxide, body plethysmography, helium dilution technique, and nitrogen washout technique. So I will tell briefly about each of this. So first is the diffusion lung capacity of carbon monoxide. Basically, it is also called as the transfer factor. So it will tell us about the ability of the lungs to transfer this oxygen to the blood via the pulmonary capillaries. Okay, so this is actually done by telling the patient to take tracer amounts of a gas containing carbon monoxide, because carbon monoxide has affinity which is about 200 times to hemoglobin than of oxygen, right? So this is the reason we use the tracer gas element as carbon monoxide. So once the patient takes in and he breathes out as forcefully and fast as possible. we will be detecting the amount of carbon dioxide that is present in the exhaled gases. So normally the value of DLCO, okay, will be 20 to 30 ml per kg per millimeter mercury, right? So this is the normal value of DLCO. So DLCO will be proportionate to the total lung capacity in conditions like pneumonectomy, that is post surgery, or in conditions like kyphoscoliosis. But DLCO will be disproportionate to the total lung capacity in conditions like obstructive lung diseases, right, and some kind of gaseous abnormalities exchange that is present. So whenever we see DLCO, we have to remember that it will basically tell us about the efficacy of the gaseous exchange. Next we come to body plethysmography. In body plethysmography, the patient sits inside a box, right? So the box contains a fixed amount of gas and volume. So body plethysmography is based on Boyle's law. Okay, P1 V1 equal to P2 V2. Patient is asked to take small shallow breaths over a particular duration and change in the volume of the air is measured, right? So next comes to helium dilution technique. In helium dilution technique, here similar to carbon monoxide, we have tracer amounts of helium that is measured in the exhaled gas. That is the helium dilution technique. Next we have the nitrogen washout method. In nitrogen washout method, we know that our normal air contains 71% of nitrogen and remaining will be oxygen and other gases, right? So whenever in this nitrogen washout technique, patient is inhaling 100% of oxygen and we measure the exhaled amount of nitrogen with the volumes via a graph. So the tracer amounts of nitrogen that is in the exhaled gases with the volume is measured over a period. So next we will be coming to the graphical analysis of the flow volume loops. So whatever we see as a part of the PFTs, we will also be seeing this flow volume loops, where on the x-axis it's a graphical analysis of volume versus the flow in liters per minute, right? So in this, there is actually starting of this patient, where the lower portion of this graph will be the inspiratory portion of the graph and the upper portion will be the expiratory portion of the graph. So patient inspires from the residual volume and he inspires here till the total lung capacity. So this will be the inspiratory phase and here will be the expiratory phase. So the maximum flow rate here which is achieved, that is the peak expiratory flow rate. From here the patient will be expiring back to the residual volume. So here the portion of this expiratory graph that is present, that will be divided into, first is the effort independent portion till the FEF 75. So remaining will be the effort dependent portion of this graphical analysis, right? So as I discussed earlier, we will see importance of this various parameters, like the patient starts from the residual volume and he will go and reach the total lung capacity, right? And from this total lung capacity, we will reach to peak expiratory flow rate and finally back to the residual volume, right? So one more thing that we can also discuss about is the various types of the flow volume loops that's seen in obstructive and restrictive type of lung diseases, right? So when we are coming to, when we see the below two graphs, right, and this graph, right, and these are the basic types of flow volume loops which we may encounter usually. So here first is, we can see that in picture number 1, we can see that there is basically an increase in the total lung capacity and there is a decrease in the residual volume. The shift of loop is towards the left. So this kind of graphical representation with the concavity seen in the expiratory limb is seen in obstructive lung disease, right? Second type of this graph 2 which we are seeing, here we see that there is a reduction in the total lung capacity. Okay, and apart from that there is also a decrease in the residual volume. We see that the graph has shifted towards the right. So this is seen in case of restrictive lung disease. Okay, this is in case of restrictive lung disease. Next we come to another type of graph, that is here, where both this inspiratory as well as expiratory limbs seem to have been shortened. So this is in case of fixed obstruction. So fixed obstruction can be intrathoracic or extrathoracic. Okay, both of them will have similar kind of graphs. So fixed obstruction, it is seen in cases, conditions like goiters or endotracheal masses. So here we see both the inspiratory and the expiratory curve would have been affected. Next we will see this is the variable obstruction. Variable obstruction, we see that in intrathoracic type of obstruction, inspiratory limb will be normal. Okay, in intrathoracic type as well as where this one is the extrathoracic type. Okay, so in intrathoracic type, we see that the inspiratory limb is normal. This is seen in conditions like in case of tracheal or bronchial tumors, which will cause expiratory flow obstruction, right? Second is extrathoracic variable obstruction. This here we see that the inspiratory limb is affected, but the expiratory limb is normal. So this is seen in conditions like vocal cord palsies, neuromuscular diseases, right? So these are the laryngomalacia. So these are the diseases where we see there is a variable extrathoracic obstruction. So here we have briefly discussed about what is a flow volume loop and what are the various basic types of flow volume loops which we may encounter in the PFTs. So coming to the last portion where we will see about the test for the cardiopulmonary interaction. First comes the stair climbing test. So stair climbing test, we ask the patients whether they are able to climb 2 flights of stairs, right? Each flight of stair is about 4 meters. So 2 flights of stairs means we will see in terms of the maximum oxygen that is consumed during exercise, that is VO2, right? So VO2 for 2 flights of stairs will be more than 12 ml per kg per minute. So if they are able to climb 5 flights of stairs, then their VO2 will be more than 20 ml per kg per minute. Okay, so all this will be predicted in terms of post-operative pulmonary complications. Next we come to the 6-minute walk test. In 6-minute walk test, patient is asked to walk for 6 minutes as swiftly as possible. So the distance that is travelled by the patient is measured in terms of meters or feet. Okay, in a 6-minute walk test, generally patient should be able to travel more than 2000 feet. Okay, that suggests that their VO2 will be more than 15 ml per kg per minute. Okay, how do we calculate the VO2? From the feet or the meters travel. There is a formula, VO2 is equal to distance that is travelled in meters divided by 30. So this is how we calculate using the 6-minute walk test. Remember that whenever there is a extensive dyspnea or whenever there is a desaturation by fall of this oxygen by more than 4%, it's a sign to terminate these tests. Okay. Next we come to the shuttle walk test. In shuttle walk test, there are 2 cones, right, which are separated by 10 meters apart, right, and we see for the distance that is travelled, and if they are able to travel more than 400 meters, then their VO2 will be more than 12 ml per kg per minute. Okay, so this is the shuttle walk test. Then we have cardiopulmonary exercise test, which is a topic in itself. But here we see the patient that uses like a cycle ergometer to which connected is saturation. We see for the VO2, we see for the carbon dioxide exhaled. We'll be also seeing about the ECGs, and we'll also see the spirometry. So various things will be coming together for the CPET test. So these four, especially the first three, are the clinical tests which we do to determine for the cardiopulmonary reserve and the interaction in the patient. So we have come to the end of this video. We have seen in this video about pulmonary function test, its uses, indications, contraindications, and within the pulmonary function test, we have seen what are the tests which is used for determining the mechanical ventilatory function, test for seeing the gas exchange, and test for seeing the cardiopulmonary interaction. I have tried to make this topic as brief as well as clear as possible. If you have any queries, do let me know in the comment section below. I'll come next time with a brand new topic. Till then, keep supporting. Thank you.